The key focus here is going to be on the word degenerative, and what you need to understand is that in these particular disorders, what's going to happen is you're going to lose or degenerate neurons. So imagine for a moment that this is a coronal section through the brain. Of course, you have gray matter, and then underneath that gray matter there's white matter. And then, of course, for example, here are ventricles. So there are two ventricles here, so these would be the lateral ventricles. And then adjacent to the ventricles, you often have additional gray matter. Now, this additional gray matter represents the deeper neurons present within the brain. And what you need to know about the degenerative disorders is that you're going to obviously degenerate neurons. And so the degeneration can occur up here in the cortex. And when you degenerate the neurons of the cortex, that's going to result in dementia. In addition, you can degenerate the neurons in the deeper structures of the brain. In particular, the key structure that we're going to focus on is something called the basal ganglia. The basal ganglia are neurons present within the deeper brain that are important for movement. And therefore, if you degenerate the neurons of the basal ganglia, that's going to result in movement problems. And so this is the paradigm that you need to have in your mind concerning the degenerative disorders. Degenerative disorders are characterized by the loss of neurons, and of course that's going to be within the gray matter. And you can lose neurons within the cortex, and when you lose neurons within the gray matter of the cortex, that's going to result in dementia. Or you can lose neurons within the brainstem and the basal ganglia. But really the key idea here is the basal ganglia. And when you lose these neurons, that's going to result in movement disorders. The first of these disorders is Alzheimer's disease. This is a degenerative disease which involves the cortex, in particular the neurons present in the gray matter of the cortex. And of course, when you involve the cortex, you're going to create dementia, as I've just explained. And it so happens that Alzheimer's disease is the most common cause of dementia. Now, to understand Alzheimer's disease, you do need a little bit of a background, so let's take a step back. This is a neuron, and I'm drawing for you the cell membrane of the neuron. And present on this cell membrane of the neuron is a receptor, which is derived from a protein called amyloid precursor protein. Now, we don't know what this receptor does, but what we do know is that when this receptor is being broken down, remember that it's a protein, it's going to be used, and over time it's going to be broken down and then recycled. So when this protein is broken down, it normally is broken down by an alpha secretase enzyme, which results in an alpha byproduct, which can then be turned over without any problem. However, sometimes it can be broken down by a beta secretase, which results in a beta product, and the problem with that beta product is that it cannot be turned over, and instead it deposits as an amyloid. And this is called A-beta amyloid. So A-beta amyloid, when it's produced, cannot be broken down, and then it begins to deposit within the brain. And it's the deposition of A-beta amyloid that then results in Alzheimer's disease. Again, very simplistically, amyloid precursor protein gets cleaved. That results in A-beta amyloid. A-beta amyloid deposits within the brain, resulting in Alzheimer's disease. The clinical features of Alzheimer's disease are all based on dementia. Now remember, dementia is memory loss plus cognitive dysfunction without any loss of consciousness. So this is sort of the definition of dementia. And so these patients get a slow onset memory loss. It's important to note that it's slow onset. It takes years to develop. And it begins with recent memory, and then it progresses to distant memory. Over time, they get progressive disorientation. They begin to develop cognitive dysfunction and begin to lose motor skills and language skills. In addition, they can develop behavior, personality changes. Eventually, the patients become mute and bedridden. And what's very important to note about Alzheimer's disease, especially early in the disease, is you do not get focal neurologic deficits. So, for example, you wouldn't see features of Parkinson's disease, such as a pill-rolling tremor or akinesia or an expressionless face. In addition, you wouldn't see features of Huntington's disease like chorea, which are these random purposeless movements of proximal muscle. So focal neurologic deficits will not be seen early in this disease. When you consider the epidemiology of Alzheimer's disease, most cases are sporadic. I like to take a step back and just remind you that if this is Alzheimer's disease, you have the sporadic form, and then you also have something called the early form. Now, the key feature in the sporadic form is that the major risk factor is age. So with time, there's an increased risk of developing the sporadic form. And of course, this sporadic form is predominantly a disease of the elderly. Another important association here is that the risk is increased with the epsilon 4 allele of apolipoprotein E. And that's particularly high yield. Board examiners really like to go after that. This epsilon 4 allele increases the conversion of amyloid precursor protein to the beta form, and that then of course results in extra deposition of that beta form, resulting in A beta amyloid, which then of course results in Alzheimer's disease. And another thing that examiners like you to know is that there is a decreased risk with the epsilon 2 allele of apolipoprotein E. And so that's a particularly high yield association. Now if you're having trouble remembering that, it's kind of easy because 4 is higher than 2, and so 4 has the increased risk, and the epsilon 2 has a decreased risk, if that helps you. The second important form is the early onset form, and in the early onset form you don't necessarily see this in the elderly, but you see it in patients who are younger, and that's what we mean by early onset. Now the key important associations here are, number one, there is a familial form in which patients have a genetic mutation that's transferred through the family, and the key genetic mutation that results in early onset Alzheimer's disease is called presenilin. Now there are two genes that can be involved, presenilin 1 and presenilin 2, and the key mutation is actually present within presenilin 1. So mutations in presenilin 1 can result in familial cases of Alzheimer's disease, which would give you early onset of disease. The second association here is that there's an increased risk of the early form in patients with Down syndrome. In fact, by the age of 40, a large number of patients with Down syndrome will have developed Alzheimer's disease. Now this is particularly high yield, and examiners love to go after it. One of the essential principles here is that, of course, in Down syndrome you have 3 copies of chromosome 21. And remember, and very high yield, that the amyloid precursor protein that eventually results in the formation of the A beta amyloid is actually present on chromosome 21. And so because the patients with Down syndrome have 3 copies of chromosome 21, they have an extra copy of amyloid precursor protein, and hence there is an increased production of the A beta amyloid. And so that again is a particularly high yield board association. The diagnosis of Alzheimer's disease is a presumptive diagnosis. It's made clinically, but only after excluding all other causes of dementia. Now the final confirmation, however, requires pathology. So it would be done at autopsy. However, of course, autopsy is often not available. But the true final diagnosis of Alzheimer's disease is actually both clinical and pathologic, and you put all of that data together to give a final true diagnosis of Alzheimer's disease. An additional type of dementia is called vascular dementia. The idea here is that you've got a problem with the blood vessels, for example, hypertension, atherosclerosis, vasculitis, which decreases blood flow to the brain. That decreased blood flow to the brain will result in multifocal infarction and injury, and that will eventually result in dementia. Now the way I think about this is to simply go back and remind myself that when you have global cerebral ischemia, which again was one of the cerebrovascular disorders that we covered, I told you at that point that you can get mild, moderate, or severe global cerebral ischemia. And in the case of moderate, I told you that you would get damage to areas of selective vulnerability. For example, one of the areas that was going to get damaged was layers 3, 5, and 6 of the cortex, which represents the pyramidal neurons. Now imagine if you're knocking out pyramidal neurons from the cortex, what you're really doing is knocking out the gray matter of the cortex, and of course that could eventually result in a dementia. In addition, recall that I told you that another select region of damage would be the hippocampus of the temporal lobe. Now when you damage the hippocampus of the temporal lobe, you're going to create problems with memory. And of course memory is also an essential component of dementia. And so vascular dementia, one way to think about it is that it is a consequence of moderate global cerebral ischemia. And of course this is important because if it's a vascular dementia, you might be able to alleviate the vascular problem and therefore improve the patient's symptoms and prognosis. So this is important to know that it is a relatively common cause of dementia in the elderly. Parkinson's disease is a degenerative disorder in which you lose neurons. However, instead of losing neurons predominantly in the cortex, you actually lose neurons in the deeper gray matter structures of the brain. Now one of the most important gray matter structures in the deep brain is the basal ganglia. The basal ganglia helps to regulate movement. We'll talk about that in a minute. And in this particular case, i.e. Parkinson's disease, you are going to lose the dopaminergic neurons in the substantia nigra pars compacta, which is part of the basal ganglia. Now, in order to really understand this, we have to go to the whiteboard. Let's remind ourselves that the cortex communicates with the basal ganglia, and the basal ganglia then sends its input back into the cortex, and the purpose of this loop is to help to regulate movement. Now, the key processing center of the basal ganglia is called the striatum, and what you need to know about the striatum is that the striatum has the ability to send stimulatory signal to the cortex or inhibitory signal to the cortex. Now, in addition to receiving input from the cortex, the striatum also receives input from the substantia nigra pars compacta. And the dopaminergic neurons in particular of the substantia nigra pars compacta will release dopamine. Now, when they release dopamine, binding of D1 receptors on the striatum will result in extra stimulation to the cortex, and binding of D2 receptors will result in decreased inhibition of the cortex. And so the overall effect of dopamine is to increase stimulation to the cortex and decrease inhibition to the cortex, and both of those are going to work to increase cortical function so that you can increase movement. And so the substantia nigra pars compacta has an effect on the striatum. This whole thing, by the way, is called the nigro-striatal pathway, and this pathway helps to initiate movement by increasing the overall signal to the cortex. Now imagine if you knock out the dopaminergic neurons of the substantia nigra pars compacta, which is what happens in Parkinson's disease, you're not going to get this increased stimulation to the cortex, and that's going to result in the movement disorders that are seen in Parkinson's disease. The clinical features of Parkinson's disease are all based on the fact that you've knocked out the dopaminergic input to the striatum, in particular the dopaminergic neurons of the substantia nigra. And of course, with that decreased input to the striatum, you're going to have decreased input to the cortex, and so you're not going to be able to generate movement as well. In particular, these patients get tremor. It's a pill-rolling tremor at rest that disappears with movement. They get rigidity. This is this cogwheel rigidity of their extremities. They get akinesia, bradykinesia, which is slowing of all voluntary movements. One example of this would be that they get an expressionless face. It's as if they can't move even the muscles of the face to smile, for example. And then they can get a shuffling gait, again, because they're not able to establish their movement, and they get postural instability. All of this can be remembered by the mnemonic TRAP, T-R-A-P. Over time, patients with Parkinson's can develop dementia. It's relatively common. However, it is seen late in the disease, for example, years into the disease. If a patient has early onset dementia, for example, within the first year of diagnosis, that suggests a different disorder, which is called Lewy body dementia. And what's important about Lewy body dementia is that, of course, you get dementia with Parkinson's-like features. They can also have hallucinations. However, they get cortical Lewy bodies, which means that they have a lot of Lewy bodies within the gray matter of the cortex. And of course, when you knock out the cortex, that's what's going to give you the dementia. So late dementia is part of Parkinson's disease. Early dementia, for example, within 1 year of the development of Parkinsonian features, would not be called Parkinson's disease. Instead, it would be called Lewy body dementia, and that's because you've got Lewy bodies in the cortex of the brain.